Okay. So good morning, everybody. Perhaps you can show my face, then that's better. Okay. Good morning, everybody. Welcome to Munich. We are in preparation of everything here, and we are almost ready. First, I just want to introduce my team. On the left side is Andreas Eichen. He will perform the procedure.
Good morning.
On the right side is Birgit Lindebner from Edwards. She will support us in the preparation of the valve which we want to implant. And there is our nurse, Karin Hermes, and in the background, perhaps you can't see them, is Professor Vogt and Andreas Kühn. They are responsible for the echo. And first of all, I would like to ask Conny Frenzel to introduce the first patient. Please, Conny.
Good morning, everybody. I'm Conny Frenzel. I also work here at the German Heart Center in Munich. So I just want to introduce the patient. Can you hear me? Is it fine?
Next slide, please.
Okay. So we did a small PowerPoint presentation. The lady is a patient. She's 53-year-old. So maybe we can. Okay, just put the next slide. I just put the actual problem of the patient. She has a severe tricuspid regurgitation.
We can't hear you through the microphone.
Which means it's a failing biological tricuspid prosthesis. And okay. So the primary diagnosis was a pulmonary valve stenosis and a severe pulmonary valve and a tricuspid regurgitation and an ASD. The history or the procedures, first in '64 there was a commissurotomy of the pulmonary valve done, and then almost 30 years later the pulmonary valve was replaced, and there was done divigaplasty of the tricuspid valve, and the ASD closure was done also. And then in 2008 there was a homograph replacement performed, and another tricuspid valve plasty. And then in 2011 there was a tricuspid valve replacement with a biological prosthesis, a perimount 27 millimeter was done. And then in the next slide we can just see the clinical status of the patient. She has intermittent chest pain and a reduced exercise tolerance since last year. And then in January this year, she was admitted at our hospital for a right heart decompensation. She has the NYHA state 3. And we've seen the echo, severe tricuspid regurgitation with a dilated right atrium and a slightly dilated right ventricle and reduced right ventricle function. So we planned a transcatheter tricuspid valve implantation, what you can see right now.
Yeah, Conny, thank you. I think we start with the echocardiography. Please, Professor Vogt and Andreas Kühn. Can we see the echo pictures live from the TE? Echo, please, on.
Okay, are we on screen? Can
you
you
can
hear
just
me? Good morning.
We can hear you, but we can't see the echo still. Can we see the echo, please? There we are.
So here is the horizontal plane of the TOE, so the probe is posterior. You see the enlarged right atrium, and you see also a slightly enlarged right ventricle here. And what you can also see here is the valve, the perimount, 27 millimeters, and the red color is regurgitation. And you also see a slightly flow acceleration, the blue, where you can see aliasing, so there's also a mild stenosis. And if we pass more to a horizontal view, you see the valve here. Here in the middle, like a fast view from deep transgastric, and you see here, this is the valve. And in the middle, you see a central regurgitation, nearly the whole valve in anterior-posterior direction.
Okay, Manfred, thank you. And we had measured some pressures. Perhaps we can now show the right atrial pressure of this patient. The patient has a V wave of, this is the right ventricle, yes. The had a V wave of over 20 millimeters of mercury, so indicating that there is severe regurgitation from the hemodynamic data as well.
Rechter Vorhof. Rechter Vorhof.
Okay, let's start with the angiographies, which we already did. Can we see the angios, perhaps? Okay, there are no angios, obviously.
That's the right atrium.
This is right atrium. This is right atrial pressure. Can we see it in another scale so that we can see that it's really a regurgitation? This is online, sorry. I think we go now live to the angiographies. Very good. Andreas, can you make a comment to this angio?
Well, this is a pigtail angiography into the right ventricle. You see the pigtail, and we angulate it to 30 degrees to the right. So we have a nice lateral view of the valve. I think this, Peter, this will also be the plane that we use for implantation. You see a slightly enlarged, like Manfred said, slightly enlarged right ventricle. There's some extras, but there's also diminished right ventricular function, and there is severe tricuspid regurgitation.
Okay.
Also, the myocardium and the whole structure of the right ventricle, for me, looks cloudy and very abnormal.
Yeah, okay. So what we will do now is we will introduce a stiff wire into the left pulmonary artery and start with the introducer, with the insertion of the introducer, and show you our plan. Because this is a 27 millimeter perimount, the recommendation is to implant a 29 millimeter sapien valve, which we then will show you how to prepare and to implant. So can we go live on angio now? Any questions so far?
No, I think that sounds good.
John, I have the problem that I can't hear you almost. I think we have to give a little bit more sound on our speakers here.
It looks very good on the angiogram that very clearly defined the severity of the TR.
Okay, Carlos. So we take
Okay.
we take a Lunderquist wire for the implantation. And we went through the valve into the left pulmonary artery with an angled pigtail catheter. Now,
so you're gonna put the wire in the pulmonary artery, or you're gonna try to coil the wire at the apex of the RV?
No, we definitely want to have the wire in the pulmonary arteries to get really a reliable stop for the wire, and I think we get more stability that way.
Right, so you're not concerned with the deployment of this valve, tilting the valve towards the RVOT?
Yeah, you mean that it could be that the valve will not be parallel to the old valve, but a little bit in an oblique way, right? Is that your question, Carlos?
Right. I mean, because of the wire, and it's obviously I'm gonna guess that you're gonna use a stiff wire.
Right.
So it's gonna drive that angle coming from the IVC across the prosthetic valve,
Yeah.
And orienting that delivery towards the RVOT.
Yes, I got the point. No, we rely on the phenomenon then that when you inflate the ball, the balloon fully, that the orientation of the balloon inside the valve will give us the right orientation for the implanted valve as well. Do you agree, or do you prefer to put it in the apex?
I personally prefer to have the straight orientation when I deploy, because the balloon itself will not, in my experience, does not give you that realignment of the coaxiality of the valve that you're deploying within the coaxial of the valve that is in place.
Okay, we will see it in a minute. I think we can force the balloon a little bit in the horizontal way by pushing the wire so that it bends a little bit, and then the alignment before we inflate the balloon will get a little bit better. So what we do now is we introduce...
One more comment from the audience.
Okay.
Joachim?
Hello? Yeah.
Hello.
Peter, this is Joachim. What I understand is that 27 millimeter would be the outside diameter of your paramount valve,
Right.
and you've got stenosis. Do you think 29 millimeter is not going to be too big? Maybe the 26 would be okay, no?
Right, this was exactly our concern as well. However, we rely on the experience of Edwards, who said in the aortic valves, where this situation that you have a perimount of 27 millimeters is quite often for valve-in-valve implantation, they would recommend a 29 millimeter valve, because a 26 could be a little bit too large or not be fixed enough. So we rely a little bit on the recommendation of Edwards in this case. But I wanted to show you the introducer, because the introducer of the 29 millimeter valve is a little bit different from the other ones, and perhaps we can have the camera on our hands. Perhaps you can go with the camera over there. Yeah. And what you can see, lights on.
1 minute.
So, just a second. Okay, can we have the camera on now? So here's the introducer. You know this introducer from the Sapien Pulmonic with this 3 valves inside the hub. But what you can see here is that the blue extension of the sheath has a dark line, and this dark line is silicone, so that this is a 20 French sheath that we can, by pushing the valve, the mounted valve through the sheath, dilate this sheath for a short time period, and then it will get back, so that the stress for the groin is minimal. Okay. So now we go to prepare the valve. Perhaps we can have the camera on the table. Lights on, please.
Peter, ich halte den Draht fest,
Ja.
der rutscht.
And camera on, please. Okay, so here we are. So we have a special delivery system here. This is the handle of the 29 millimeter valve. Can we zoom in a little bit? Okay. So what you can see here, there is these black things which indicate that you can flex the whole thing. When I turn the handle, you see the black ball going back, and the more the more I turn this, the more the sheath gets flexed. So this is one feature. The other one is that you can control the balloon with this metal mandrel, and when I pull at this mandrel, we can have a look at the tip of the balloon. When I pull the mandrel, you see that the blue pusher is able to push the valve, which has to be crimped in the proximal part of this system. The valve will be pushed to the end of the balloon inside the body, so that we have a crimped valve in the slim part here at the proximal part. Perhaps Birgit, you can show it. Yeah, there the valve will be crimped, and inside the body we can push it over the balloon. Okay, so we start crimping. We can show the valve perhaps, and Birgit will go ahead preparing the valve.
Peter, would you comment on the height of the 29 as opposed to the 26 also? That also we may be another issue why to use a 29.
Yeah. So we crimp it in a similar way like the pulmonic, and when it comes out we can show the stent. Birgit, perhaps you can show the valve and its feature that it has indeed 4 cells and a larger covered portion, and the height of the valve is how many millimeters? 19.1 millimeters. Yeah, so it's larger, the stent is larger than normal. Yeah, so now it's pre-crimped, and the next step for crimping is that we get this qual crimp tool, which should avoid that through the mesh of the stand, tissue of the valve gets damaged or get out during the crimping process. This is just to secure that the valve is can be crimped without damaging it. Yeah, very good. And now follows a two-step crimping as we know it from the Edwards pulmonic. Perhaps we can have a look inside the crimping tool. We introduce the balloon, and the valve has to be crimped to the proximal part of the balloon. This is pre-crimping, and you see the orange stopper there, over there, for the first stop of the pre-crimping. Everything is very standardized. Now the stopper gets shortened, and I would say the sock has to be removed, and the valve can be finally.
Would you also comment on the orientation of the valve, the way you load it, as opposed to what they normally do for aortic implants?
Carlos, thank you for that, of course. Well, of course, the whole system is made for retrograde aortic valve replacement, and so normally the valve has to be crimped in the other way, not as we are supposed to do it normally with pulmonic valves. And one concern is, of course, that you have to push the valve over the balloon inside the body against the direction of flow. So there was some concern that the leaflets perhaps can be damaged when they were pushed against the flow direction. However, when we crimp it now completely, you will see that the whole valve is so firmly attached to the system that it is very difficult to imagine that these valves should be get damaged or folded inside in the wrong way, because the whole system is so stiff. Okay, so we confirm, everybody, that the inflow side, which you can see, there is this thread, this green thread marking the inflow side, and you see the coverage of the proximal three cell lines and the uncovered tip. So this is the way pulmonic or tricuspid valves normally should implant it. So now we crimp it firmly, as you see here, and now we can close or bring the pusher to the valve till we hear a click. I heard a click, I don't know whether you have heard it, and the valve is ready. Now we take the introducer, similar to that in the pulmonic valves, to get through the introducer sheath, and it's very strong valves inside. And now we are ready to implant. Perhaps one item is, so we flush the introducer once again to get the air out, as you can see here, and we flush once the guide wire line at the tip, that way. And similar to the other Edwards valve, this is a volume-controlled inflation of the valve. We have 33 milliliters of saline inside the indeflator to get the valve to its nominal size. Okay, Andreas. Are we prepared?
Yes.
Any questions?
It looks very good so far.
Okay. Okay. So, can you go with the camera perhaps over there, then you can see the hands better.
Peter, hältst du den Draht fest, dass der nicht zurückrutscht?
I control the wire. And here we go. Can we see the hands of the operator, not the echo, please?
We receive the echo.
Can we see, please, the introducer and not the echo? Connie Frenzel, please do your job. Okay.
Okay,
I think. Okay. Then the introducer can take note. Sorry for that. We don't want to see the echo. Can anybody change it, please? Yeah. Okay. And we need now angiography. Fluoro, please. Because we want to see the end, the tip of the sheath in the angio. Tschüss, los.
We have fluoro.
Okay, here we are. There's the tip of the sheath and the tip of the introducer.
Ich fahr weiter rein.
Ja.
Aber jetzt müssen wir ja noch die Klappe crimpen, oder?
Okay, now we have to release the valve over the sheath, but we do it far up. Okay. Yeah. We push it more up. There the valve is coming. Okay. So I think this is enough. This is enough. Perhaps we can zoom out a little bit. Can we zoom out? Vergrößern.
Einmal.
Okay, let's see. No, the other way around. And once again. And once again. Okay. Okay, so then we now we pull and the balloon to the stand.
We can't see the stent on our screen. Or the valve.
And
Still
we have
centered
to go
below
up.
the diaphragm.
No, don't push. Yeah, there's a stop now. I can't pull more. Now, here we are. There was a stop. And we have to bring the valve inside the two markers. There's a lot of resistance, but now, here we are. We need fluoro. Okay, so now it has made click. And now we can turn a little black button here on the table. Do we have my hands on? The camera on my hands, please. Okay, so this button, it was very good, so as you had with the small picture and the fluoro. I turn this handle, please angiography.
It is fluoro.
Fluoro. Frau Frenzel, fluoro. So and now when I turn the handle, the valve comes up. You see it? And now we can adjust it directly between the blue. So this should be on it. Okay. Okay, now the valve is mounted and we can bring the valve into the position we want to. Andreas, please. Okay.
Peter.
Yes.
How can you be sure that you're not avulsing the valve with that?
It's a mechanism
Once again?
that the way of loading of the sapien valve. The sapien valve, this new one, is that you crimp the valve. The delivery system doesn't prevent the valve to go further out. And then once the catheter is inside, then you pull back on the balloon to load
it. But this is done for the aortic valve. Here
the same thing.
Yeah, but they reversed the valve. So how they... I understand in an aortic valve it's not going to be traumatic because the balloon goes on the back of the valve. But now how do you know you're not avulsing the valve now that the valve is inverted for the pulmonary position?
Joachim.
Sorry, there were many opinions now.
That's a great concern because this was the initial concern when you do this because it's all done for the aortic. So it was this extensive analysis
sorry guys.
For the pulmonic position using this system and it proved that there was no avulsion of the valve leaflets. This, of course, does not necessarily mean 100% because that's one of the issues still, that they could evolve while they're bringing the balloon back, revert the leaflet. So still a concern, but they have done testing.
Sorry guys, we don't know whether you have a question or a comment. We just go ahead, okay?
Very good.
You go ahead, and looks very good. We're watching your precise movement.
We do the
we
do the practical job and you the theoretical, okay?
Ich glaube, wenn du jetzt ein bisschen schiebst am Draht, wird er sich noch gerade ausrichten. Aber es kann auch sein, dass es mit dem Ballon richtig wird.
Let's speak in English and do the discussions for everybody. So now we have
Peter, what maneuvers you gonna do? You see the orientation of your prosthesis as you have it now.
Yes.
In relation to the magna valve.
Right.
What are you planning to do from the handling of the wire and catheter to have that valve coaxial?
Just a second. Do we have to remove the pusher? Okay. First we have to remove the pusher. I show you in a minute, Carlos. Yeah. Fluoro, please. So I take the pusher back because then there is more stability. There is more flexibility in the system. Okay, now we go a little bit back with the valve. And now you mean, well, this is a really awkward position because, of course, we don't want to implant the valve in this angle. However, when we try to push the system and push the wire, I push the wire now a little bit and Andreas will push the system. You see that it gets more horizontal, you see? And when we now inflate the balloon, then the balloon will do the rest.
Would it help if you exchange the wire for a softer wire? So in other words, just leave it the way it is and put a softer wire that will allow for a better bending.
Yeah, that's a good point. I think that is perhaps a good idea. However, I am convinced that we get a good result in this way as well.
Go ahead.
Okay. I think somebody has to control the wire. How do we want to do it now? Willst du den Wire selber drücken, Andreas?
Okay, ich hab's.
Okay, Andreas, you give the command when everything is okay. Are you happy with it? Okay, we start the inflation very slowly. We want to have the valve with the first third inside the ring of the prosthesis. And now you see how it aligns a little bit better. And now it aligns perfect. Okay, I deflate. So what do you think?
Very good. Absolutely impressive.
Beautiful position.
Okay. Now we can take the whole system out. Hopefully without the valve. Here we go.
I think the height of the valve is absolutely on the dot.
Yeah.
And again, the orientation looks absolutely fantastic.
Yeah, and you have seen not only the balloon has got horizontally, but the valve, the prosthetic valve, the surgical biological valve, oriented a little bit to the balloon. So the tissue, or they come both from both sides together to get it in the right alignment. Okay, I think we do an angiogram now, and then we are done.
Excellent.
And I have to admit, from the flaring of the 29mm valve, I think it is the right choice. Because normally you would expect 27mm valve, 29mm implant, that there should be more flaring, but there isn't any. There is just, the flaring is just right, I think. What do you think?
I think it looks beautiful, Peter.
Okay. So we take the angled pigtail in. Okay, here we go. Angio.
Gleiche Menge, gleicher Fluss.
And perhaps we can have the echo at the end. That would be when we take the catheter out, then we have a final view with the echo. Ja, das ist gut. Das ist okay. So ist okay. Okay.
Gleiche Menge, gleicher Fluss.
Okay, there's a trace of regurgitation due to the catheter. And now we take the catheter out, have perhaps the right atrial pressure once again, and can parallel have a look to the echo, please. Rechter Vorhof, blau. Blau spüren. Manfred, would you comment on the findings? Yes.
Can't hear.
We cannot hear anything.
Okay. Can we have? Okay. What we well, you see it. Everybody can see it. There is practically no regurgitation at all. There's less acceleration at the inflow, perhaps due to less regurgitation volume, which has to go over the valve in comparison to before. And what we see on the pressure, can we have the pressure line again? That now the systolic pressure in the right atrium, which was
der rechte Vorhof,
which was 22 at the beginning, is now at about 18, and so there is an immediate decrease in that at that point. Okay.
Excellent.
So
That's a beautiful result. Thank you very much.
Thank you, and we'll see us later at lunchtime for the second case from Munich.
Great. So we're going to be moving on.
Bye.